Well, hello, everyone. I want to thank you for joining today's webinar, Intersectionally in Health Research. We do have a fantastic speaker lined up for today, but before I introduce our speaker, just a little bit of housekeeping rules. So during the presentation, we ask that you turn off your mics and cameras. Following the presentation, we will have time for Q&A, and at that point, we ask that you turn your cameras back on. To ask a question, please unmute yourself and ask the presenter directly. We are recording the presentation portion only, and so you'll find that on CDTRP's webpage, and if you like, you can watch it again later or share it amongst your networks. And with that fun stuff out of the way, it is my pleasure to introduce our speaker, Dr. Olena Hankivsky. So Dr. Hankivsky is a professor with the School of Public Policy and director for the Institute for Intersectionality Research and Policy at Simon Fraser University, based out of Vancouver, and is currently on leave from the University of Melbourne as the director of Center for the Health Equity in the Center for Population and Global Health. Dr. Hankivsky is trained as a political scientist. She is an internationally recognized expert in gender mainstreaming, gender-based analysis, and intersectionality-based analysis. She has over 20 years experience working across academic, government, NGO, and international organizations, including the World Health Organization, the United Nations, and the Organization for Economic Cooperation and Development. Her publications have been featured in Lancet, BMJ, and Social Sciences and Medicine. In 2019, she completed the Palgrave Handbook of Intersectionality and Public Policy with Dr. Julia Jordan Zachary. In 2020, she was appointed as a commissioner to the Lancet Commission on Gender and Global Health in recognition of her expertise in intersectionality. So thank you for joining us. And with that, I pass it on to you for your wonderful presentation.
Well, thank you. Thank you very much for the introduction. And I'm so pleased to be with you here today. I was really intrigued by the invitation because although my work is in health research and policy, I have never ventured into anything to do with tissue or organ donation or similar types of issues. So I come to you as more of an intersectionality expert, but the talk inspired me to look a little bit into the research in the area so that I could hopefully branch the fields together a little bit. And I'm also hoping that you'll be able to provide some input and some ideas as well into our conversation today. So thank you very much for being here, and I really look forward to spending the next hour with you. So the title of my talk, as you all know, is Intersectionality and Health Research. And I thought I would just give you a little bit of an overview of what I was planning to cover, which is really basically from what is intersectionality and some of the key tenets and some of the reach that intersectionality has made in health research and policy, some of the resources that are available. I'm going to talk about intersectionality in the Canadian policy landscape, as well as in the health research landscape as well. I'll talk about some of the guiding questions that one should ask when conducting intersectionality-informed research. I'll talk about a few examples from recent research in the area of organ donations. And then I'll talk a little bit right at the end around some implications and conclusions as well to the topic. So that's basically the overview. So what is intersectionality? I'm hoping that it's not necessarily the first time that some of you have heard the term or the concept of intersectionality. There are many different definitions of intersectionality that are out there. This is one potential definition that can be drawn on that I put together in 2014. But before I actually get to explaining the definition and some of the key tenets, I really want to acknowledge the fact that intersectionality has very deep historic roots in the work of Black critical race scholars and also activists. So it's not something that has emerged from feminist studies or gender studies. And it's not something that emerged in academic settings. In fact, it has very deep roots in activism at the turn of the 19th century. It was a term, though, that was coined in 1989 by critical race scholar Kimberly Crenshaw in the United States, who really wanted to emphasize that Black women do not just experience racism or discrimination based on gender, that there's something about the combination of these two, in addition to other factors, that makes their experiences unique. And those experiences have not been properly reflected in legal approaches to discrimination. And more importantly, if we think back historically to some of the movements that had existed in the second wave of the women's movement, that were really looking only at or primarily at gender discrimination. So it was a really corrective to saying that the experiences of women in relation to discrimination and inequity are not all similar. They're not the same. We can't homogenize them, that there are very important differences that need to be paid attention to. So when we talk about intersectionality, intersectionality is really bringing to the forefront that human beings are shared by the interaction of different social locations. So it's not just, say, race and ethnicity, indigeneity, gender, class, sexuality, many other social locations, disability, migration status, religion, that there's something that's happening at the interaction of all these that shapes our lives. And importantly, that what happens at the individual level of these experiences occurs within the context of connected structures and systems of power. So as some example, things like the law, policies, state governments, other kind of political and economic unions, and reflected in the media. And that through such processes, we get interdependent forms of privilege and oppression that are shaped by things like colonialism, imperialism, racism, homophobia, ableism, and patriarchy that they're created. So intersectionality really tries to highlight that inequities, well, human experiences, human lives, and then often inequities are created at the intersection of these different social locations, power relations, and experiences. And there's been a number of different metaphors, visual metaphors that have been proposed to try to capture this multi-level dynamic phenomena framework approach to thinking about research and policy. So just randomly choosing a kind of a kaleidoscope that's bringing together all the different possible factors and locations and variables and showing that they're constantly moving and changing. There's the traffic intersection that comes from the work of Kimberly Crenshaw, who coined the term intersectionality. And she said, look, we can have all of these roads that can represent different axes of our human lives or experiences, so gender and race and socioeconomic status. And we can all be going down these roads, but it's actually what happens when these roads come together and intersect, which allows us to better understand people in their entire humanity, in their entire composition. But I think my favorite metaphor of all time is that of the sort of the baking metaphor that you see there at the very bottom. And the idea here is that when you bake, you start with separate ingredients, but once you start mixing them up, it's very hard to distinguish, for example, where's the flour, where's the butter, where's the vanilla, where's the sugar, because they all become enmeshed into one. And that's very much a very powerful metaphor for an intersectionality approach. So the key tenets of intersectionality can be summarized in the following way: that people belong to more than just one category at the same time. So more than just women, men, an Indigenous person, a migrant person, etc. That there's no presumption of the importance any factor or combination of factors, whether we're talking about things like gender or race or ethnicity or socioeconomic status, that when we think about social categories and how they affect people's lives, that we're not just adding them together. We're looking at the relationship between them, and we're looking at the way in which they interact. And that individual experiences of those interactions are embedded in those broader systems and processes of power that I mentioned just a moment ago. And that, researchers and policymakers and activists must really consider their own social position, role, assumptions, and power when they take an intersectionality approach. So it's this engagement in a process of self-reflexivity that helps us to think about, how do we set priorities? How do we set the directions in research that we set? How do we approach policy work and activism? That all of those things about ourselves we bring to our work and can affect the way in which we conduct, for example, research. And intersectionality, finally, is really explicitly oriented towards transformation, building coalitions between different groups, but most importantly, working towards change and social justice. So the way that I like to describe it is, it goes beyond just describing a situation, describing inequities, describing barriers, describing challenges. It's also about trying to determine solutions for those kinds of challenges. Intersectionality, since it came into the health realm, or actually, let me just back up and say that since Kimberly Crenshaw coined the term intersectionality, it's had international reach. And of course, different jurisdictions, depending on where you are in the world, are in different stages of development in terms of engagement with intersectionality. There's different foci in jurisdictions. But in the realm of health, I would say that intersectionality came into the discipline of health research and policy probably now about 10 to 15 years ago. I would say the uptake has been probably most noticeable in the last 5 years, and probably even most noticeable since the outbreak of COVID, which I'm not going to talk about here so much, but I'd happy to chat about during the Q&A. But in all the applications of intersectionality in the research and policy space, there's been a real recognition that there's a value added of bringing this perspective to understanding and responding to health experiences, outcomes, and inequities. So there's a number of different resources that also exist for those who want to engage with intersectionality work. At the Institute for Intersectionality Research and Policy at Simon Fraser University, which was mentioned during the introduction, we've actually developed a number of different primers to help people bring intersectionality to qualitative, quantitative, mixed methods research, to policy analysis, and even just a primer on intersectionality 101 that just goes through the basics of intersectionality. And all these primers right now are actually getting updated to a second version to reflect new developments in the field. And in particular, the policy analysis framework here on this slide has just been evaluated. It's been taken up in more than 30 countries around the world by a variety of different health researchers and policy decision makers, and has been really taken a really important place, I would say, in a lot of health inequities work. And the framework itself here contains two very important resources for those who want to do this kind of work. It really shows the method of how to apply intersectionality in policy analysis. And secondly, it also contains a number of case examples that can lead people. And it also outlines the kind of principles that one should use in intersectionality informed analysis that reflect back to some of the tenets of intersectionality that I introduced to you today. So the importance of recognizing intersecting categories, engaging in a multi-level analysis, putting power front and center in one's work, engaging in self-reflexivity, being aware that your analysis has to take into account differences in time and space, and that is geographic location, recognizing diverse kinds of knowledges. So we often think about quantitative, qualitative, mixed methods, but we also are increasingly talking about Indigenous ways of knowing and how that is an important base of evidence to be taken into account. And of course, the commitment to social justice and equity in terms of that transformational impetus of intersectionality. So how is intersectionality now making its way into the mainstream of the Canadian policy landscape? Well, we see it importantly in two places. One is the introduction of gender-based analysis plus framework. I'm not sure if that is something that is familiar to you, but we did have a federal department previously known as Status of Women Canada, and Status of Women Canada had introduced a gender-based analysis framework for all federal departments across Canada to use when developing policy, to really take into account the different needs and experiences of both women and men. And in around 2010, Status decided that this approach was no longer adequate for getting at the diverse experiences of both women and men, and they wanted to develop something that would better reflect on intersectionality impetus. And I was invited by the then Minister of Status of Women to help them put together the groundwork for shifting to what now is called gender-based analysis plus. The plus being an attempt to bring intersectionality into the analysis of a gender analysis. And of course, Status of Women no longer exists. It's now called Women and Gender Equality Canada. But GBA Plus is recognizing that while gender is a major factor in this analysis, that other factors such as age, education, language, geography, culture, and income have to be taken into account. And that's part of integrating intersectionality within the federal government. Now, we also see this shift happening specifically in the health space, whether you're looking at places like Health Canada or PHAC, FAC, they're all engaging in the health version of GBA plus, which then turns into a sex and gender-based analysis plus, because the sex variable is important in, of course, health research. And one of the probably the most well-developed approaches to SGBA plus exists within the Institute of Gender and Health, within the Canadian Institutes of Health Research in their strategic plan, where they lay out that SGBA plus, that is a sex and gender-based analysis plus approach, is absolutely essential for understanding not only the biological components of sex and how gender influences health and well-being, but also looking at other factors that intersect with both sex and gender to influence health. So this is a really important development that's happened, but one that I want to just point out took a bit of a longer time in the health sphere. So we had GBA plus introduced at the federal level in 2012, but it wasn't until 2018 that we saw that reflected in the strategic plan of, for example, the IGH and part of the Canadian Institutes of Health Research. And I would say that there's still a lot of conflation that goes on within all the health bodies around either saying sex and gender-based analysis or sex and gender-based analysis plus. It's not always used consistently. Nevertheless, anybody who now is applying for health research funding from the Canadian Institutes of Health Research has to demonstrate how they address SGBA plus in their application. And in the most recent round of applications for the spring competition of the CHR, for example, SGBA plus was really front and center in applications, which just shows you how important knowing how to do this work is becoming in the health domain in Canada, but not just in Canada, in many other jurisdictions abroad. So what are some of the guiding research questions that can be used if you want to engage in this kind of intersectionality informed approach? Some of it is actually quite simple. Some of it is just starting with being open to the fact that there can be many different factors that shape and determine health. That is not starting any study with an a priori expectation or assumption that what we're going to hone in on are sex differences, and from there we're going to really understand the lay of the land, or we're going to focus in on indigeneity and we'll sort it all out, or geographic location, or socioeconomic status. That we can't be using any of these as kind of proxies for understanding the whole plethora of experiences. And we have to really tread carefully then in making sure that those are reflected not just in our research questions, but also in terms of our inclusion, exclusion criteria in conducting research. So we want to make sure that the research design that we propose, right from the research question right through to the way in which we're collecting data and analyzing data, captures potential relationships and interactions between those different factors that I mentioned, and really thinking about a multi-level analysis. So even if you are collecting individual level data and you've actually gone the step to thinking about different factors that come into play, that you don't just leave your analysis at the individual level, but you try to then contextualize it in broader structures at a more kind of meso or macro level. So linking those individual experiences to things like, have there been really important policy changes that have occurred? Have there been really important political developments that have occurred? Have there been economic crises or health crises that have occurred? It's not just about capturing the individual in a more fine-grained way, but linking those individual experiences to those broader processes and structures as well. Another important question to ask is the sample size that you're collecting adequate for capturing the diversity between and within groups, especially because in health research, there's a tendency to deal with groups in a homogeneous way, right? There's often this binary that's set up between men and women, or Indigenous and non-Indigenous, or lumping together migrants into that one category of migrants, or BIPOC in terms of, okay, so we've got this category now that is Black, Indigenous, people of color, and, although it has certain powerful potential to have that as a category, we want to make sure we're just not lumping everybody together and assuming a homogeneous or static experience within those groups as well. The other thing that intersectionality challenges to do is to really challenge the often male and female differences that are asserted in a lot of research that is out there. Have we really taken into account those intersecting factors in relation to sex and gender in a very explicit way? And again, as I mentioned in previous questions, does the study really contextualize the research findings undertaken within a human subjects within those broader social structures and processes of power? So let me just shift now then for the last few minutes to some applications and examples that maybe more relevant to you. And again, I'm not the expert in this field at all. So these are just things that I read about in the last few days as I was preparing for my meeting with you. First of all, I was struck when I went into Google searches and looked at things like tissue and organ donors that you'd think that it was just all kind of white people giving to white people, because all the hands around these things all seem to be very white. And so I'm actually using them to make a point that even the visuals are making certain kinds of assumptions. But as I understand it, a lot of the research that I have seen that is tackling issues of diversity or intersectionality is trying to better understand how to increase incentives and eliminate barriers for donors, both living and deceased, so that in turn, more would be available that could greatly improve other people's chances of life-saving interventions, and specifically life-saving transplants. And I just want to share with you a couple of studies that I came across that I think are quite interesting in terms of moving that intersectionality needle forward. The first was in relation to kidney recipients and donors, a 2021 study that I'll get into the details in a second. But the study just outlines some key information that is known, that globally it's shown that women are less likely to be kidney recipients than men, but more likely to become kidney donors, and that there's no real conclusive evidence as to why women donate more and receive fewer kidneys. Now, this was kind of the setup for this study that called itself an intersectional gender analysis study of kidney recipients and donors. So let me just present to you what they were trying to do in this study. So it was, as I said, just recently published. The site of the study was in Barcelona, and the authors looked at two groups of women that they described as having biological kinship ties with recipients, that is mothers and sisters, or women that they refer to as having sociocultural ties as wives to recipients. And one of the things that they just lay out in terms of the WHO is that all the women in their study donated their kidneys to men except for two biologically related donations that went from a mother to a daughter or between sisters. So that's the first thing to know about the sample. But their findings basically showed that even in the group, if we're looking at women and moving away from that kind of binary comparison between women and men, or assuming that all women experience this in the same way, that they said that there's differences between the two groups that they found. The first difference in group one, that is women with biological kinship ties with the recipient, is that they perceive donation as a naturalization thing, that donation within a family was even expected or considered to be a norm. For the second group, those were the donor wives, that there were two phenomena that really stood out. One is that women were motivated because they had witnessed their husband's diseases, they had followed the progression and the consequences, and that of course they felt that they really wanted to donate for those reasons. But a very interesting finding of their study was that the reason that women also said that they wanted to donate was not simply for these altruistic reasons, or these maybe culturally defined reasons, or these obligations between spouses, but they actually saw it as a way of avoiding becoming caretakers for their husbands and avoiding having to step in to take full economic responsibility for their family. So it was very much considered to be an act of empowerment and an act of maintaining autonomy. So even within this study, we see that these two groups of women had very different motivations and experiences around donation. And it really opens the door to seeing that there are many other types of factors and considerations that we could start to consider in this work. Now, the problem with this study that I also wanted to point out is that at nowhere in the actual study do they provide a definition of intersectionality, that they do use gender as an entry point for an intersectional analysis, which happens a lot. But if we're doing a proper intersectional analysis, it's not about assuming the importance of any one factor as being the most important. So that kind of entry point should be resisted, but it happens a lot in research. And the question that I would pose to you is, in looking at some of the points of differences between these two groups of women, are there other factors that should have been taken into account that weren't taken into account that could explain even more of those different kinds of experiences that they found? So I would argue that some of the issues for intersectional analysis in this space is really around these important issues. First is that there are going to be huge differences and diversities in terms of knowledge around organ donation and registration, attitudes towards organ donation, willingness to talk with family or friends about organ donation, different views related to religion, faith, and culture, other kinds of personal worries, a fear, or even some of the literature talks about disgust regarding organ donation, losing parts of bodies, and a lack of access and provision of information or resources regarding organ donation. That if we take that intersectional lens, we'll see that there are many different differences and factors that need to be taken into account to better understand how individuals in different groups may be responding to these kinds of issues. In another UK study that I just want to briefly mention around looking at interventions to increase organ donation in specifically minority ethnic backgrounds, that the researchers here found that those, generally put together media campaigns with messages around organ donation actually don't do the trick, because what is needed more are educational interventions that can actually reach out to the specific needs of different ethnic minority groups, that have that kind of very interpersonal element, that can target specific concerns that may be delivered by trusted members of a local community in familiar environments, and that can also provide immediate access to registration. That it's this idea that this one size fits all that often happen in public media campaigns around health issues just aren't going to reach all populations and groups in the same way. And so the authors of this particular study said more work has to be done on using the intersectional perspective that can help to better understand the interactions between different ethnicities, genders, or races. And while the differences want to be revealed, that we also don't want to lose focus on the fact that there might be some similarities across these different groups that should be taken into account in the work as well. So just a few final words then about intersectionality's implications for research is just, again, to emphasize that social identities are not independent or unidimensional, but are multiple and intersecting, and has to be taken into account. So just think about the experiences of, a low-income Indigenous woman with a physical disability living in a rural area. Well, you can't just clump her into either being a woman or being Indigenous or being disabled or living in a rural community. All these things have to come into play, and that we can't assume the primary importance and contribution of any one of these kinds of categories or locations if we're talking about developments, manifestations, management of diseases, or predicting health behaviors. And it's not enough, as often happens in health research, to enumerate or show differences between men and women and how they relate to a particular issue or problem. We have to start with the assumption that differences among women and among men may be greater than differences between women and men. And the same goes for other groupings that are often used. So it's important to think about which women and which men are we considering, which groups should be compared to one another and why. And let's not just look at the differences between groups, but also within groups, so that we don't homogenize in that way as well. And if we do that, we start to look more at the heterogeneity effects and the causal processes that produce health inequities. We get at more fine-grained conceptualizations and analyses that do really reflect people's lives and the experiences of populations. And we get to engage in that multi-level analysis that always contextualizes the individual to broader processes of marginalization and oppression and or privilege, for that matter. And this, of course, leads to better evidence and better interventions that are tailored to social contexts of affected communities and their needs. And also it assists policymakers and practitioners to deliver more effective and efficient programs and services, and extends to the empowerment of citizens who can come together and organize across different groups around similar kinds of issues, and that can build resilience and alliances and strategies as well. So just to conclude, I would say that intersectionality really does resonate with the common sense recognition that people's experiences are influenced by a multitude of factors and relations of power at individual, societal, and structural levels, and human health and related behaviors can't be accurately understood by prioritizing or only looking at one category or even a predetermined constellation of categories. That the list of factors really should be open-ended, and if we do try to capture them in more of their entirety, we're going to get a better sense of what profoundly affects our lives, our opportunities, our health, the behavior, the manifestations of illness, and the behaviors and outcomes that we have as well. So as a final little thought, without doubt, intersectionality complicates everything. And even though it's challenging, it does force us to get a little bit more sophisticated and fine-grained about how we see the world. And it makes us to be a little bit more self-reflexive in how we approach our research, how we collect our data, how we analyze our data, how we present our data, and how that data then enters into the sphere where it is impacting on policy, programming, and services. And I think that's about it for what I want to present. And I would really welcome now having an opportunity to chat to you about any of the research you might be doing and or any questions that you might have about intersectionality.
Well, perfect. Thank you, Dr. Hankivsky, for the presentation, and also for highlighting some of the intersectional analysis within the organ donation and transplantation world that you had on that slide near the end. So I do invite everyone to turn on their cameras and unmute yourselves for any questions, and you can ask Dr. Hankivsky directly. And just a note that this section is not being recorded. So I've stopped recording now.